I would like to now introduce our first speaker this evening, Dr. Lisa Weinstock. She's the Director of Women's Digital Imaging of Ridgewood, New Jersey. She founded Women's Digital Imaging in 2004 to provide breast, pelvic, and bone imaging studies for women in a comfortable environment with immediate results to minimize anxiety. So without further ado, Dr. Weinstock, the floor is yours.
Thank you so much. I just would like to thank the whole Sharsheret community for giving me the opportunity to participate in this webinar tonight. My goal is basically to make some sense of all the breast imaging options. Next slide. As this cartoon demonstrates, there's a lot of confusing information out there. Every day another study seems to conflict with the recommendations of the day before. And I just want to point out that top right, this is from the New England Journal of Panic-Inducing Gobbledygook. Next slide. Another cartoon, as this one demonstrates, that the guidelines are at best confusing. Here's the doctor telling the patient you're suffering from confusing cancer guideline symptoms. We don't normally start testing for that until you're 30. So, next slide. What are some of the challenges in breast cancer screening? First, benefits versus possible harms. What's worse, a missed cancer or a false positive? A false positive means that you're working up or biopsying something that turns out not to be a cancer. Very anxiety-invoking. Now, is every cancer we find going to progress and do harm? We have no way of knowing that at this time. There are many imaging options. None of them are perfect. And that's basically what I'm going to be discussing tonight. Next slide. Sorting through some of the controversies out there. What is the best age to start screening? Do I need more than a mammogram? Is early detection too early? Next slide. Just a couple of interesting facts. Just on the bottom here, more than 250,000 women 40 and under in the United States are living with breast cancer. That's one out of six breast cancers occur in women between the ages of 40 and 49. Next slide. When should you start screening? What are the guidelines? Now, it's very important to keep in mind that these guidelines are for average risk women, not high-risk women. As Shira mentioned before, Ashkenazi Jewish descent in and of itself is considered a risk factor. So here are some of the basic guidelines. The American Cancer Society and the American College of Radiology recommends that mammography begin at age 40, not at age 50. In my opinion, consider a first baseline mammogram at 35, particularly if high risk. A general rule is to start screening approximately 10 years before your youngest first-degree relative was diagnosed. So if your mother was diagnosed at age 35, you should start screening at 25. I think this may have been a Freudian slip here, but the cartoon went over the U.S. Preventive Task Force recommendations, which basically states that screening mammograms should be every 2 years biannually between the ages of 50 and 74. And this cartoon is basically leading women under 50 to their ultimate death. Next slide. Part of the reason that there are so many conflicting recommendations is that many of these recommendations are coming from different biased angles. Unfortunately, science in some ways is being replaced by an agenda. This cartoon, it's a little blurry, but it basically says that it takes 1,900 mammograms of women in their 40s to save one life, but only 1,300 of women in their 50s. So it's way more cost effective to only do mammograms in women in their 50s and older. That last gentleman in this cartoon on the task force says, so just wait till you're 50 and stop calling us the death panel. The studies are trying to understand populations, not individuals. And the policy recommendations are being suggested knowing that cancers will be missed. So I think it's very important that each individual become their own advocate and know their own risk. Next slide. Okay, here are some of the breast imaging modalities available to us, and I will discuss most of these in further detail a little later, but mammography, tomosynthesis, 3D, all under the category of mammography. There's ultrasound, MRI, molecular imaging, which is synonymous with molecular breast imaging, nuclear medicine imaging, there's contrast-enhanced mammography, and then just a couple of words about thermography. The reason I included it is because I think it's dangerous for women who are solely relying on this modality. There are some women out there that are refusing mammography and ultrasound and relying on the thermography. We in the breast imaging world do not consider thermography a replacement or a supplemental test to mammography. It misses way too many cancers. The FDA came out with a statement to this effect in 2011. Next slide. First, we'll discuss mammography. Mammography is the gold standard for screening worldwide. It's the only modality that has been proven over and over again to reduce breast cancer mortality if performed annually. Next slide. It's the best tool we have right now. This is mammography. It's not the only one that we need. It shows calcifications and abnormalities such as distortion of breast tissue, which we cannot see on other modalities. However, cancers can be difficult to see due to overlap of dense tissue, which I will get into a little later. Next slide. That brings us to the tomosynthesis, which is synonymous with 3D. Now, when patients hear 3D mammography, I think they're expecting a pop-up image to come out of the machine. No, it is not 3D in the way we think about 3D. It simply allows us to view the breast in thin slices. So it's basically like seeing the individual pages in a book and not looking through the book cover to cover. It's an upgraded, it's a prettier mammogram. It's the newer technology. The downside is that there is still compression and there's still radiation. In fact, the radiation dose really is an issue when it comes to tomosynthesis. With the newer software, it's the same amount of radiation when they do the standard and the tomosynthesis views. But until this point, what we call C-view tomosynthesis, it has been double the amount of radiation. I think that tomosynthesis using the C-view, which is the low dose, is going to become the standard mammography that is going to become available. Now, one of the greatest benefits in tomosynthesis is that it reduces callbacks. And we all know about the callbacks you get from the imaging facility that you need additional views. So tomo eliminates a great majority of these callbacks and eliminates the anxiety, the aggravation, and the cost of returning for the additional views. Next slide. Okay, here's an example of 2D and 3D and 2D images. As you can see on the left, this is 3D. You can see that tiny little nodule. It's well defined. You still see it on the right, the 2D, but it's not, you can't characterize it as well as you can the one on the left. This patient still needed an ultrasound. That turned out to just be a cyst. But you can see it's a much sharper image. Basically, I think tomosynthesis is an incremental step in the right direction, and I think this picture illustrates that. I don't think it's a giant leap in breast cancer diagnosis. New slide. Even with the newest, latest, and greatest technology, if the breast tissue is not on the image, a cancer could be missed. So please work with your mammotechnologist when they're positioning you. They're really not trying to torture you. They're just trying to get all your breast tissue onto the image. Next slide. When do you need more than a mammogram? Here are a few examples. If you have a personal history of breast cancer, strong family history, any of the genetic mutations, the BRCA mutations, and I'll be discussing later, there are new mutations out there that are being diagnosed. If you have dense tissue, if you have a prior biopsy, which shows a high-risk lesion, or if you had radiation to the chest due to Hodgkin's lymphoma as a child. Next slide. So what is breast density? Breast density is defined as the percentage of breast tissue versus fatty tissue within the breast. The problem is tumors are white, cancers are white, breast tissue is white. So it's very difficult to find a cancer that's hidden in the dense tissue. Breast density has recently been proven to be a cancer risk in and of itself. Some studies are showing that patients with dense tissue have as much of a 4 to 6 times higher cancer risk compared to women with fatty tissue. As you'll see later, I think it's on the next slide, breast density and dense breasts, it's a spectrum. So we're talking about the extremely, extremely dense tissue, and that's just about 10% of patients. It's completely normal to have dense breast tissue. You just need to know that if you do have dense tissue, your mammogram may not be as sensitive or as helpful as someone who has fatty tissue. Next slide. A picture's worth 1,000 words. The bottom images are demonstrating breast density. Bottom left is showing fatty. Bottom right, extremely dense. And the ones in the middle are all in the spectrum of heterogeneously dense. Now, on the top right, the top left, that's a cancer in a woman who has fatty tissue, easy to see on the mammogram, easy to see on the next image on the ultrasound. The following, with the yellow arrow on the top, third image, is showing a cancer easily visible in the ultrasound. On the ultrasound, the tissue, the surrounding breast tissue is white, the cancer is dark, and it's clearly visible. That same patient, this is her mammogram, the yellow arrow is pointing to where the clip is, where I put her clip is where the cancer is. There is some vague density there, but you would never have seen it on the mammogram itself. The next image, top right, this woman came in she felt this cancer with a high-grade invasive cancer. Her mammogram is extremely dense on the bottom. You can't find it, not even on the tomosynthesis views. You cannot see her cancer. So that's basically demonstrating all the different varieties of breast tissue. Next slide. Depending on what state you're in, you may have recently received a letter or a comment about your breast density in addition to your mammogram results. 24 states, I think it's up to 24 now, I think as of last week, now have breast density notification laws. New Jersey has notification just letting you know that you may have dense breasts. Pretty confusing. Why all this chaos? Dense breasts is not something new. We as radiologists have put breast density into our reports to your doctors. The problem is that depending on where you went for your mammogram, you may not have known that you had dense tissue. The radiologist knew, the technologist knew, your referring physician knew, but the patient did not know. And the patient did not know that their mammogram may not be as sensitive in finding a cancer as, like I mentioned, somebody with fatty tissue. A group of women whose cancers were missed on a mammogram and whose cancers were found at a later stage formed an advocacy group called Are You Dense? And they went state from state trying to get this law passed that patients should be notified of their breast density. So that's what this is all about when you see on your letter telling you that you have dense tissue as well as your mammogram reports. And it's important in order for you to be able to know that so that you can discuss it with the radiologist, with your clinician. I think on the next slide, or maybe it was the slide before, there's a great website that they formed called densebreast-info.org, full of information about what to do if you do have dense breast tissue. Next slide. Now, I know I have dense tissue. What do I do? These are the different modalities in addition to mammography and 3D mammo. Ultrasound is a non-invasive test, extremely accessible, no radiation involved, no injections involved. It finds an additional 2 to 4 cancers per 1,000 women screened. Next slide. Here's an example of a cancer found. Again, on the right, there's the cancer in the ultrasound, very clear. On the left, you could see a little metal clip in what we know is a cancer. This is a tomosynthesis view. We do not see the cancer on the tomosynthesis view. Next slide. So I know what you're all thinking because I get asked it every day. Why can't I just skip the mammogram? I have dense tissue. You can't see anything on it anyway. Why can't I just have ultrasound? And the reason is the mammogram is still the gold standard. There are certain things that we cannot see on ultrasound, such as calcification or subtle distortions. So even if your mammogram is not so sensitive, or let's say 40% sensitive in finding a cancer, and the ultrasound is 40% sensitive in finding a cancer, together they increase the sensitivity of finding a cancer. So they work together. You can't get out at this time of having a mammogram. Next slide. A few words on the physiologic modalities, just a quick review. There's breast MRI and molecular imaging. As I mentioned, molecular imaging is the same as breast-specific imaging, many names. It gets very confusing. MRI looks at the vascular, the blood flow. Molecular imaging looks at the cell metabolism. Mammography and ultrasound look at the anatomy. So these are extremely, next slide, these are extremely sensitive tests. And, of course, whenever you raise the sensitivity of finding a cancer, you also lower the specificity, meaning you're going to find things that aren't cancer. And that is a problem with both of these tests. MRI has its drawbacks. They're on the slides. I won't get into it. And, of course, molecular imaging has its own drawbacks. But they're extremely sensitive tests. Here are a couple of examples. Next slide. These are cancers that have lit up on BSGI, which is molecular imaging. What's important here on the left is here you can see a cancer lighting up. To the extreme left is the mammogram. We see nothing. The next column, you can see the cancer lighting up. The next column is a mammogram. Yes, we all see that cancer. The next column on the molecular imaging, you see the cancer, but the pink arrows are pointing to some activity that's going out from the cancer, meaning this changes surgical management. That cancer is not just what you're seeing, that round mass. So the surgeon has to make a wider excision there. Okay, next slide. Be careful of statistics. In my opinion, tomosynthesis is not a replacement, and I showed you examples for supplemental imaging. There was a lot of hype last year. It was all over the news about this JAMA article that was claiming that tomosynthesis finds 41% more invasive cancers than standard mammography. That made no sense to me. After further investigation, looking into it, the formula that they used was kind of a skewed formula. So on this graph here, digital mammography finds 3 cancers. With tomo, 4 cancers. This is per 1,000. Ultrasound found 6 cancers. So using the same formula, ultrasound finds 103 to 138% more cancers. So it's important to know, and if you go to MRI or molecular imaging, you're probably over 200% or more. So it's important to know that the modalities work together to improve cancer detection. There is no breaking news about anything. Next slide. Individual risk assessment. I think this is we're going to be hearing a lot about this, and that in general, in medicine in general, is crucial in the area of precision medicine. Next slide. Some conclusions on supplemental screening. For all women, I think digital mammography with tomosynthesis is going to become gold standard. For average risk women who have heterogeneously dense tissue or dense tissue, probably ultrasound in addition is a good idea. For patients who are low to intermediate risk with dense tissue, consider ultrasound, possible MRI or molecular imaging. For higher risk women, and by higher risk I mean family history or anyone who has a previous personal history of breast cancer, consider breast MRI or molecular imaging. And also just considering staggering your imaging studies in intervals. We're trying to space them so that we can catch the interval cancers. Next slide. What can you do? Know your risks, your personal and family history. I don't think I have to say it to this group, but of course the father side is important, just as important as the mother side. Know your breast density. Make sure to ask about supplemental imaging. I'm not going to talk much about genetic risk profile, but BRCA negative diagnosis does not give you a free pass. I think it's important to know that there are newer genetic testing. There's new genetic testing that's now available called MyRisk. We're now able to test for a whole slew of other genes that we weren't able to test for before, and I think we're going to find a lot of these genes in the moderate risk families who've tested negative for the BRCA genes. Next slide. Here are just some of the modifiable and non-modifiable risk factors. I had a laugh when I was looking at this one. Gender was non-modifiable. I think we have to change that now, that may be a modifiable risk. But there are things we can't change, family history, in all seriousness, gender. There are things we can, body fat, physical activity, and last slide. So in conclusion, remember, breast cancer is overwhelmingly a curable disease, particularly if found early. Even late-stage cancers are kept under control with chemo and hormonal therapy. In order to find breast cancer early, we have to remember that breast cancer detection is a puzzle, and we need all the tools we have to put that puzzle together. Each modality adds to the picture. And that's really it.
Great. Thank you very much, Dr. Weinstock.